Hello, everyone. This is the Cervical Cancer Prevention and Screening Guidelines and Practices lecture, and this is Dr. Schminke. In this lecture, I'll be talking about cervical cancer screening guidelines and practices and the prevention of cervical cancer through vaccination. Cervical cancer is caused by a virus called the human papillomavirus, or HPV, which is primarily sexually transmitted. Worldwide, cervical cancer is the fourth most frequent cancer in women, with an estimated 604,000 new cases in 2020. This year, we estimate 14,000 women, more than 14,000 women in the United States will be diagnosed with invasive cervical cancer, and that 342,000 women will die from cervical cancer. About 90% of those occur in low and middle income countries. The signs of cervical cancer include bleeding from the vagina, painful sex, abnormal vaginal discharge, and abdominal pain in the lower abdomen. The treatment options for cervical cancer include surgery, radiation, and chemotherapy, and that's beyond the scope of this course to discuss those. But our focus in this lecture is on prevention and screening. Let's get started. In this PowerPoint, in addition to the information on the first slide, we're going to be talking about risk factors, prevention, screening, and treatment related to cervical cancer. The risk factors for cervical cancer, of course, include the virus that causes it, HPV, human papillomavirus. HIV infection, however, compromises the immune system to the point that it can't deal with the viral infection. And so people with HIV infection are greatly at much greater risk of developing cervical cancer, as are people who smoke with tobacco. And honestly, other substances haven't been looked at, so I can't say if smoking weed or something else increases your risk of cervical cancer, but tobacco use does increase your risk, again, because of the way that it compromises our immune system's ability to attack viruses and help the abnormal cell growth regress. Using birth control pills for more than 5 years, or for 5 years or more, I should say, is associated with increased risk of cervical cancer, in part because people aren't using barrier methods, so their cervixes are getting exposed to more virus, to more HPV. Giving birth to 3 or more children is associated with cervical cancer because of all of the trauma associated with cervical dilatation, that's the opening of the cervix to let a baby come through, and the healing that happens. It's a time of rapid cell regrowth, which the more times you go through that, the more risk you are of having cervical cancer. And finally, having multiple sex partners, because it places you at an increased risk for exposure to human papillomavirus again and again, is a risk for cervical cancer. The human papillomavirus is a sexually transmitted pathogen that causes anogenital and oropharyngeal disease in males and females. Persistent viral infection with high-risk HPV genotypes cause virtually all cancers of the cervix. The high-risk HPV genotypes or types 16 and 18 cause approximately 70% of all cervical cancers worldwide, and types 31, 33, 45, 52, and 58 cause an additional 20%. You need to know 16 and 18 of all of those subtypes. There are 3 HPV vaccines that have been approved by the FDA, but currently only one of them is available in the United States, and that is the Gardasil 9, the 9-valent HPV vaccine targeting types 6, 11, 16, 18, and 31, 33, 45, 52, and 58. These vaccines are meant to prevent initial HPV infection and subsequent lesions that are associated with HPV, warts and cervical lesions. There are vaccines in development that we hope will someday combat existing HPV-associated lesions. So in other words, you could be infected with an HPV subtype. We'd give you a vaccine and it would actually make any lesions you have regress to normal. And we don't have that yet. None of those are on the market yet. So we can only prevent HPV infection that has not yet occurred with these vaccines. To prevent cervical cancer, the recommendations for vaccination with Gardasil 9 begin for girls as young as 9 years of age. Although our target audience is really the 11 and 12 age group, it has FDA approval from the age of 9 and on. And if you're between 9 and 12 years old, we recommend getting 2 doses, with the second one occurring 6 to 12 months after the first dose. The dosing is quite different in women between the ages of 13 and 26 who did not already get vaccinated. In those women, Gardasil 9 is administered in a 3-dose schedule, with the second dose 2 months after the first and the third dose 6 months after the first dose. In women over 27, we especially encourage vaccination of previously unvaccinated healthcare workers who work in gynecological settings, dermatological settings, or in operating rooms where there could be aerosolized HPV virus that they could be exposed to during surgical procedures or minor or significant surgical procedures. Other than healthcare workers, you really need to take it on an individual case basis, whether someone should be vaccinated after the age of 27 or not. If my personal sense is that anybody who's sexually active with a new partner after the age of 27 should be vaccinated, because we are trying to protect them against all of these 9 viral subtypes. And even if they've been exposed to 1 or 2 of them, vaccinating them and protecting against the other 7 could have long-term health benefit. Ideally, we're going to vaccinate everyone before their sexual debut, but for someone who's sexually active, even if they've had a prior HPV positive test result or a lesion, they can still benefit from protection against these other viral subtypes. So consider vaccinating them. However, you need to be aware that their insurance may or may not cover the vaccination after the age of 26. If someone has missed doses at any age, go ahead and give them the next dose. And consider it complete if they are less than 12 years old. If they're over 13 years of age when they come back, they're going to need 3 to complete, a total of 3 shots to complete the series. So they need 2 more. And for someone over 27, they're of course going to be on the 3-dose schedule as well. And they're going to need a total of 3 doses to be fully vaccinated. This vaccine, Gardasil 9, carries a post-vaccination label that says you should keep them in your office, either sitting or lying down, for 15 minutes after administering the vaccine to limit any related syncopal episodes. That's about everything that I want you to know about cervical cancer prevention through vaccination. Now let's turn our attention to cervical cancer screening processes. There are 3 things you need to be comfortable doing related to cervical cancer screening. First of all, you need to be comfortable with the tests that we use and the frequency schedules. We'll talk about that in the next several slides. We will also be talking about how you actually do these tests, and it is also covered thoroughly on pages 111 to 123 of your textbook. Secondly, you need to know how to interpret the results you get from these tests when they come back and they aren't normal. And finally, we will briefly discuss common treatments and follow-up. You're not going to be responsible for extensive knowledge of treatment for cervical cancer in this course, but you should be familiar enough that you can describe them briefly to patients. There are two ways that we can screen for cervical cancer. The first is a pap smear, which is short for Papa-Nicolau smear, and HPV testing is the other way. Pap smears are simply taking samples of cervical cells to see if there are any precancerous changes. One of the most common of those is caused by HPV infection, and it's called a coilocytic change. That's spelled out in the notes section. Coilocytic changes mean that the cell has changed shape because it's infected with HPV. The pap test also can identify actual cancer cells. In the old days, we would use glass microscope slides to collect specimens of cervical cells. Nowadays, what we use is an automated liquid-based pap cytology test where we just take our samples and mix them in a vial of fixative, and then it's a liquid preservative, and send that off to the lab for analysis. HPV testing is detecting DNA or RNA from certain high-risk subtypes of HPV in cells that are taken from the cervix. The HPV tests actually can identify HPV infection earlier than we'd see coilocytic changes on a pap smear. The HPV tests come back as either positive or negative. This is much more straightforward than interpreting abnormal pap smears. A negative HPV test means that there's no high-risk viral type, no virus that's associated with cervical cancer. And a positive HPV test means that there is a high-risk viral subtype that's been identified that could be associated with the eventual development of cancer. Now, this HPV test is for the cervix. It's not for other genital areas or for the mouth. And interestingly enough, there's currently no test to detect high-risk HPV in people who have penises. There's a urine test that exists, but it isn't licensed for clinical use. It's only used in research settings. And to that, I just say, sigh. Collecting an appropriate pap smear starts with the instructions the patient has been given when they call to schedule the appointment. Ideally, you want to make sure you're seeing people 10 to 18 days after their last menstrual period. LMP stands for last menstrual period, and we count that from the first day of bleeding of their last menstrual period. Tell your patients or have the person scheduling appointments that they should not douche, they shouldn't have any semen in their vagina, tampons, foams, jellies, creams, any medication for 48 hours before you do the pap smear. And you also don't want to be doing the pap smear in the first 6 to 8 weeks postpartum. There are so many hormonal changes that are happening, and the cervix is still healing from the dilation and delivery of a baby, and you're likely to have abnormal results even if everything is normally occurring in the cervix at that point. Another thing that's very important is that you need to train someone in your office to fill out the lab requisitions correctly. The menstrual status, previous history of abnormal pap smears, the patient's risk factors, the source of the specimen, is it on the endocervix in the cervical canal, or is it just on the outside of the cervix? That's very important to note. What kind of contraception the patient uses, especially if it's a hormonal method. Make sure that who fills this out knows that you can have hormonal methods of birth control that are not birth control pills, because I've worked with people who I had to educate about that. Relevant clinical findings from your exam need to be noted on this lab requisition. Whether there was bleeding, is the cervix friable, which means that when you touch it, it bleeds? Are there visible lesions? Those are things you want to make sure to have on that lab requisition. And this is ultimately your responsibility as the provider doing the test. Make sure that before you begin the exam, the patient has emptied their bladder and that you have obtained consent to be not only doing a pap smear, but even to touch them, and reassure them that you're going to be talking them through the procedure. Then you get the patient positioned. For our purposes, you are going to use a lithotomy position. It is possible to do pap smears in other positions, and sometimes it's necessary, but I would say that unless you are a specialist in women's health, you do not need to know how to do pap smears anyway but a lithotomy position. The pictures on the right here are of the typical collection tools that we use: a spatula, a combined spatula and brush, and a cyto brush or cervical broom. We're not going to test you on the names of those things. I just want you to recognize them in the office setting. The importance of proper specimen collection and submission really can't be overemphasized. At least 1/2 to 2/3 of false negatives on pap smears are the result of patient conditions that were present at the time of the sample collection and submission, and the skill and knowledge of the person who obtained the specimen. So don't be the person who inadvertently fails to collect a good pap smear. The performance of a pap smear is probably going to be uncomfortable for many of the women you take care of, but it should never be painful. And so inserting the speculum correctly is an important skill that you'll have a chance to practice in a different course, I believe. But I'm here to tell you that you need to always have a chaperone. Protect yourself against accusations of inappropriate behavior by having a chaperone in the room with you. Also, when you're getting ready to perform a pap smear, please select, or any kind of pelvic exam, select an appropriately sized speculum and warm it with water if it is not already on a heating pad and warm. And make sure it's comfortable to the touch, to your touch, that you're not going to burn your patient if it's been warmed on a heating pad that's set too high. I'm not going to detail all of these steps that are written here for you with my narration, but I do want to remind you that the only appropriate lubricant is warm water. Otherwise, you can obscure the very specimens that you're trying to collect. I'll let you read through the rest of this, and I'll be back on the next slide. If you have properly placed the speculum and you're using the appropriate size speculum, you should be able to see the cervix as it's visualized in this picture in the center of the slide with the Q-tip. If you can't see it, you need to think about getting another provider to help you, because it could be the patient size or the patient mobility limitations that make that difficult. The thin prep instructions here are to help you read through how it is that we prepare that liquid-based cytology test. In addition to the instructions here, I usually actually scrape the brush along the inside of the container before I remove it after swishing it around for 10 seconds in order to make sure I get as much of the sample as possible into the liquid medium. Make sure you tighten that container well so that it doesn't leak all over the plastic bag on its way to the lab. More than any other guidelines in my 30+ years of practice, it has been these cervical cancer screening guidelines that change the most often. Because of evolving testing technologies, I think you can rest assured that this will continue to be the case for at least the first 15 years of your practice. Prior to the age of 21, cervical cancer is really very rare. It's like 0.1% of all the cancers that are diagnosed in this age group are cervical cancer. Starting at the age of 21, though, the benefits of cervical cancer screening start to outweigh the potential harm of screening. Now, what are those potential harms? Well, doing a lot of what we call colposcopies and treatment procedures where we start taking parts of the cervix off or burning structures that could end up with causing scarring or damage to the organ itself, to the cervix. Now, from age 21 to age 30 or right under 30, there are conflicting recommendations now between the United States Preventive Services Task Force guidelines that recommend initiating screening at age 21 and continuing with cervical cytology every 3 years until the age of 30, and the 2020 American Cancer Society guidelines that challenged this, saying that you can now wait until age 25 to initiate screening and that you can just do primary HPV testing. Then you don't have to do Papa Nicolau smears. The problem with that, and that it can be done every 5 years. So you do it at 25, you do it again at 30. Now the problem with that is that currently there are 2 tests that are approved by the FDA for primary HPV DNA testing. They're called COBAS and BD on Clarity. They are not readily available in most clinical settings in the United States, and therefore this is not really an option for most of us in practice. I will say that in resource-poor environments, I think you're going to see adoption of this every 5-year screening, and it's going to be with the self-testing, patients using tampons, for instance, that they then put into a mailer and mail it off to either their health clinic or even to the lab to have the screening done. That's already very common. Well, I shouldn't say it's very common. It's already been done extensively in southwestern Virginia in the very rural parts where there's not a lot of easy access to gynecological care. The University of Virginia at Wise campus there has been doing studies for years to demonstrate that this kind of self-testing works. When we get to age 30 and above, there are several strategies that are acceptable for immunocompetent women with normal results. You can do the co-testing where you're doing a PAP and testing for the HPV virus every 5 years, or you can do primary HPV testing every 5 years, but as I just described, that's not so easily available. You can do PAP test with reflex HPV testing every 3 years, or a PAP test alone every 3 years that if it's abnormal, you'd have to go back and do more testing. Now, quite frankly, with the liquid cytology available, you can do reflexed HPV testing on every PAP, and if you are reviewing your PAPs in a timely manner when the results come back, you can quickly add reflex testing onto a PAP and tell the lab to run it if you have an abnormal PAP. So that's what, I'm not sure if you've heard this term reflex testing in your other courses, but when you have a reflex test ordered, it means that if it comes back out of normal range, you automatically do this next test. Reflexively, you do it. And that I would say that the reflex testing with a PAP or co-testing, doing both at the same time, that's what I see being done in my practice. The United States United States Preventative Service Task Force currently recommends that you don't have to do any more screening for cervical cancer after the age of 65 if you have a history of adequate screening and it's been normal, and if the patient is not at high risk for cervical cancer. Now, if you have a patient who has multiple partners, or her partner has multiple partners, then you're going to need to keep screening beyond that, assuming that they are using her vagina for sexual intercourse. So that's something you need to explore. We do not need to do any screening after a hysterectomy. So if a woman's had her uterus removed, as long as she has no history of a high-grade precancerous lesion or cervical cancer, she doesn't need any more PAP tests or HPV testing of her vagina. All of the major obstetrical and gynecological professional societies and organizations still recommend that we follow the USPSTF guidelines, which I've got listed here in Table 1. And so you see that there's not any evidence, according to the USPSTF, that we should be screening before the age of 21 or after the age of 65, with the exceptions that I talked about on the last slide and that are noted in the notes below this slide. If you perform a pap smear, you're going to get results that you have to interpret. So let's talk about how we will read the results. Hopefully, the vast majority of your results will come back as NILM, or negative for intraepithelial lesion or malignancy. And of course, those folks, the follow-up for them will be to follow the routine screening guidelines for their age group. If they are not marked NILM, then they're either going to have a squamous cell abnormality or a glandular cell abnormality. The squamous cell abnormalities are much more common than glandular. Squamous cell abnormalities range from ascus, atypical squamous cells of undetermined significance, to atypical squamous cells that cannot exclude a high-grade squamous intraepithelial lesion, ASC-H, L-SIL, or low-grade squamous intraepithelial lesions, which encompass CIN1, and I'll show you what all this looks like in just a moment, or at least a graphical figurative representation of what it looks like, which will be more useful to you, I think, than looking at the actual lesions. High-grade squamous intraepithelial lesions indicate that there's a persistent HPV infection with CIN2 or CIN3 present, and then you get full-blown squamous cell carcinoma. And within the glandular cell spectrum, you have atypical cells that are not otherwise specified, and these could be from deep in the endocervix. They could be from the endometrium if you did a really deep PAP, or if you've got endometrial cancer happening and you've got weird cells that have migrated down through the cervical canal, you could be getting endometrial cells that are abnormal there. You could also be getting glandular cells. Then there's atypical glandular cells that favor neoplastic cells, and endocervical adenocarcinoma in situ, which is abbreviated AIS. And finally, you can have a glandular cell adenocarcinoma. So let's look at a picture of what these kinds of changes represent. Here we have the progression of cervical disease after someone's become infected with HPV. On the left-hand side here, you have the normal epithelium, and over the course of many years, if left untreated, you would end up eventually, in many cases, with invasive carcinoma. Now, in many cases, the HPV infection can be dealt with by the body's immune system here in this ascus stage, this first stage here with the eyeball type cells, which are koilocytotic cells. HPV infected cells have this particular look that we call koilocytosis. And so you might see that written on a pap smear sometimes, that there's koilocytosis present. And this is what we're talking about, an HPV infected cell. And these changes could be just the abnormal cell because of HPV infection. And if it is an ascus or even a low-grade lesion, we may very well see resolution of that by the because the body's immune system can fight it. But once you get into these lower grade lesions, it becomes harder in CIN1, which stands for cervical intraepithelial neoplasia grade 1. It becomes harder for the body's immune system to actually intervene. And that certainly is the case as you progress through CIN2 and CIN3. So when we were talking about ascus and L-sil, we're talking about these early changes, and you can see how progressively you have a bigger and more prominent lesion as you progress through the infection to CIN2 and CIN3. And finally, with invasive carcinoma, you're actually breaching the basement membrane of the cervical endothelium, the cervical epithelium, and those cells can go wherever they want to in the body. It is entirely possible to regress from a higher grade lesion to a normal pap smear if the person's immune system is responsive to that. It's less likely in somebody with immunocompromised. Somebody with HIV infection is at much greater risk for ending up with cervical cancer because their immune system is not capable of reversing these trends. When we get abnormal results from a pap smear, the go-to test, the diagnostic test, is called a colposcopy. And this picture here is of a colposcope that is a fancy microscope we wheel up to the woman's vulva once we've inserted a speculum, and we get magnified views of the cervix. And we also usually swab the cervix with acetic acid, a vinegar solution, so that we can better see abnormal lesions under the microscope. We use this test when someone has an abnormal pap but are HPV negative if the abnormal pap shows a potential high-grade lesion or anything more severe on the spectrum. And if someone's HPV positive, we don't wait for a high-grade lesion. If we have an ascus pap, abnormal cells of undetermined significance or anything more significant than that, we would do a colposcopy. The next slide will show more detailed treatment guidelines. But as I've said, these change a lot. We use risk estimates to drive our treatment and diagnostic procedures after abnormal PAPs. So, as you can see here, somebody who has HPV negative normal PAP is good for a 5-year follow-up, according to this study that was published in 2020. And that the people who are HPV positive they need to have colposcopy done, or at the very least a 1-year follow-up, because of these risks that you see under the CIN3 plus cases and the CIN3 plus 5-year risk. You can see that these folks have a significant risk of developing really abnormal cells that are going to lead to cancer. You will use whatever app you've got in your office to show the appropriate follow-up after abnormal PAPs. This is just one of many potential guidelines that you might follow. If we ask you questions on a test about this, we will be giving you guidelines, and you just have to interpret the test and figure out the right guideline for it. Okay? So once we've looked at the table on the previous slide, we have determined is their immediate CIN3 plus risk greater than or equal to 4%? And if it is, then we may jump straight to some kind of expedited surgical treatment, or we may just do a colposcopy. And if the answer is no, that their immediate risk is not greater than 4%, we ask what their 5-year risk is, and that will determine how soon they need to come back. Perhaps I should have said earlier that colposcopy is a specialized skill that you need to attend a fairly extensive training session or a course to learn how to do it, and then there's supervised practice of this in order to be certified to perform colposcopies. Most people outside of gynecological offices are not going to acquire this skill. So when you have someone who needs a colposcopy or who has a more severe abnormal PAP, anything with a high-grade lesion, you're going to be referring them to, at the very least, a gynecologist. If they have extensive cancer found on the PAP, then of course you're going to refer them to a gynecological oncologist. For the vast majority of cancers that we find and significant high-grade lesions that we find in the United States, we're able to treat them with surgical procedures. Many of these are done in offices. These would include a LEEP, L-E-E-P, which stands for loop electrosurgical excision procedure, or we also do cryosurgery and laser surgery to treat most early stage cancers. We find that if the cancer spread to the uterus, we need to do a hysterectomy and take the uterus and cervix out. And if it is beyond a early stage 1 cancer, the next step is radiation, and beyond that would be add chemotherapy to this mix of treatment. But the management of this will be done by an oncologist if it's not an early stage 1 cancer. You've reached the end of this PowerPoint, and I'll be looking forward to working through some pap smears with you folks in class in next week or this week. So I'll see you soon.